Here is a risk-benefit analysis providing a synopsis of each of the different types of weight loss surgeries to help determine which one would be right for you. 60% excess weight loss could be expected after the adjustable gastric band. It is the least invasive surgical approach and does not involve division of the intestinal system. It is adjustable and there's no malabsorption. Weight loss is slower than gastric bypass surgery. Regular adjustments are critical for optimal results, and some patients may not do well with bands, experiencing poor weight loss and/or reflux, resulting in a higher reoperative rate. The sleeve gastrectomy is associated with a 60% excess weight loss and is a popular option for surgical control of morbid obesity. Patients can eat a near normal, albeit smaller meal. It is less restrictive than the band or the gastric bypass. There is a low risk for ulcers, and since we don't work with the small intestine, there's no risk for malabsorption or dumping. There's no foreign body involved, and no adjustments are necessary to induce restriction. Patients leave with adequate stomach restriction from the moment that they leave the operating room. Since it's a relatively new operation, data beyond 3 years is still awaited. Complications are uncommon and seem to be related to division of the stomach. Since the operation involves only removing the outer stretchable part of the stomach and no changes are made to the gastrointestinal continuity, even if weight regain does occur in the future, patients could be converted to any of the other conventional weight loss operations. The proximal Roux-en-Y gastric bypass is one of the most common operations for weight loss surgery in this country. It is associated with a 70% excess weight loss with very well documented long-term outcomes, better cure rates for diabetes than the adjustable gastric band. There's no foreign body involved and there's no adjustments necessary. Since it involves division of the stomach and the intestinal system, there is a small risk for leaks and ulcers and strictures. Patients who are non-compliant are at mild risk for malnutrition-related problems such as anemia and osteoporosis. The medial Roux-en-Y gastric bypass is a malabsorptive type of gastric bypass associated with an excellent 80% excess weight loss track record. Weight loss is typically very durable. Cure rates for diabetes are excellent. No foreign body or adjustments are involved with this operation. Complications are primarily related to division of the gastrointestinal system, such as leaks, ulcers, and strictures. Non-compliant patients are at moderate risk for malnutrition, such as anemia, osteoporosis, and low protein levels, as well as fat-soluble vitamin deficiency. The laparoscopic duodenal switch is associated with a 75% excess weight loss. Weight loss is typically durable. Cure rates for diabetes are among the best for any surgery related to weight loss. Patients can eat a near normal meal. Since the pyloric valve is preserved, there is no dumping. Again, there's no foreign body or adjustments necessary. Complications are related to division of the intestinal system. There's a moderate risk for malnutrition, particularly in non-compliant patients. As with any other malabsorptive operations, non-compliant patients are at moderate risk for malnutrition and could develop anemia, osteoporosis, low protein levels, and fat-soluble vitamin deficiency. Patients who have had prior stomach surgery, such as a Nissen fundoplication or Hill repair to restore a poorly functioning esophageal valve, or prior stomach ulcer surgery, may be challenging to operate on laparoscopically. Prior open upper abdominal surgery could also pose a problem. However, patients who have had prior gallbladder removal, appendectomy, cesarean sections usually do not affect the choice of surgery. Occasionally, patients who have had hysterectomies or lower abdominal surgeries, such as colon resection, may develop adhesions in the small intestine that may preclude some of the malabsorptive operations. So how do you choose? Given all this information, it could be a daunting task to choose the appropriate type of weight loss surgery. It is critical that you personally meet with the surgeon to help you with this decision. There is no absolute recommendation for any type of weight loss surgery in the literature. The following is based purely upon my experience. In general, patients with a BMI less than 50 can expect equivalent results from either the adjustable gastric band, the sleeve gastrectomy, or the proximal gastric bypass. If you're someone who's averse to having a part of your stomach removed or the intestinal system divided or rerouted, are agreeable and willing to come in to be seen for periodic adjustments of the band, then proceed with an adjustable gastric band. If, on the other hand, you're unable to come in for frequent visits to the doctor's office, either because of professional, personal, or travel reasons, or desire pure stomach restriction, then proceed with the sleeve gastrectomy, because it's a conceptually simple operation that induces stomach restriction from the moment you leave the operating room and is not dependent upon multiple doctor visits to induce the appropriate amount of restriction. If, on the other hand, you're obligated to proceed with the gastric bypass because of insurance reasons, or have diabetes and are not averse to having the stomach and intestinal system rerouted, then have the proximal gastric bypass. Among the three surgeries, this has the better cure rate for diabetes and has a longer proven track record. For patients with a BMI 50 to 60, the sleeve gastrectomy and the proximal gastric bypass would give good results. However, the adjustable gastric band could also give you good results, although it has not been adequately studied in this population for us to give a definitive answer in this patient subset. For patients who desire a better weight loss, consideration should be given to a malabsorptive operation such as the medial gastric bypass or the duodenal switch. Patients whose initial BMI is over 60 are best served by a malabsorptive operation such as the medial gastric bypass or a duodenal switch. However, recent data is accumulating that shows that sleeve gastrectomy, when performed as a first stage operation, reduces the risk for subsequent operations in the high-risk patient population. Patients who have had prior failed weight loss surgeries must be individually evaluated to determine the best type of salvage operation. In general, it is best that you have your surgery at an ASMBS approved Center of Excellence facility by a Center of Excellence surgeon. So who's a candidate for a sleeve gastrectomy? In general, anyone with clinically severe obesity with a BMI over 35 is a candidate for this operation. Selected patients with BMI less than 35 are also well served by a sleeve gastrectomy. It is now being offered as the first step in the treatment of patients who are at high risk for gastric bypass or duodenal switch, particularly patients with higher BMIs over 55 or 60. Patients who travel a lot or are busy professionals, patients who are considering pregnancy, those who have been recommended that they have a significant weight loss prior to joint replacement therapy by consulting surgeons, are also excellent candidates for the surgery.